Well, man, I just want to say no Christmas shopping while you're listening to this webinar out there in the internet world.
Yeah. Well, hopefully we'll keep you engaged enough to stay with us, and you can get back to Amazon or whatever you're doing afterwards. But we thank you for taking your time. I'm Dr. Guy Yatros, and my partner there, Richard Drake, is in Texas. I'm in Florida. And we're here to talk about dental sleep implementation that works. That's a mouthful for me in this evening, apparently. We do a lot of these, Rich and I, and we talk about doing dental sleep and how you do it. And we're going to get into some of the systems that you need to do dental sleep. But Rich, I don't know how many lectures we do a year, but a bunch. And a lot of people come up to us and say, hey, you know, should we be doing this?
Yeah. Well, I would even back up, Guy, and say, can I be doing this? You know, I'd say we still get that question,
right.
You know, and so what does the ADA say? You know, not that they set the gold standard for everything, but they are finally coming around, and, you know, they're really saying that not only can we do this, Guy, but I think we should be doing this. That's how I read it.
Yeah. And this is recent, just October of this year. The ADA has decided to make a position about dentist involvement. And yeah, that's the way I'm reading this, is that, you know, dentists are well positioned to identify patients that are at greater risk for sleep disorder breathing. And, you know, we've been saying this for all this time, but, you know, the ADA now is getting on board with saying this. And by the way, anybody needs the full paper, we'll have a way to get a hold of us in a little while. You can just type in consult or info or something, and we'll be happy to forward you the full paper. But we're just pulling the key points out here. And the way I read that is that, hey, we're in the driver's seat for finding these patients, which we've been preaching that as long as I can remember, Rich, is all the screening things that we do and testing. Dentists are encouraged to screen their patients. I don't really know of another healthcare provider who's in a better position when you think about the fact that we look at their dental anatomy and their oral anatomy and how that affects the airway, and that we see our patients regularly. We spend a lot of time talking about that. I was glad to see the ADA is on board with this.
Yeah, I didn't think I'd live long enough to see that, Guy, actually. But yeah, they're finally getting on board, and I think, you know, Guy, we've been preaching this for a long time. I mean, as a dentist, not only should you be doing this, you know, can you do it, but you should be doing it, because we know that a lot more people go to the dentist than they do the physician. You know, I do these consults all day, every day with new patients, Guy, and you know, when was the last time you saw your dentist? You know, a year ago, you know, 6 months. How about your physician? You know, 40-year-old guy, there's nothing wrong with him. You're like, well, I haven't seen him for like 15 years, you know, or something like that. So you're absolutely right. And are there a lot of 40-year-olds out there with undiagnosed sleep apnea? Yeah, probably like 2 or 3 million of them. So yeah, well, let's get going with this, Guy, and talk about, you know, is there anybody else out there that might have a say in what we can do?
Yeah,
or should do?
We'll talk about another organization, but I want to make sure that we make the points on here that we as dentists can't make a diagnosis, and I think that's been one of the points of contention here. But we should refer the patients once we feel that they're at risk to a physician. So that's what the ADA says here. I think I want to emphasize that we didn't involve the physicians. At the end of the presentation today, we'll talk about specifically how you do that. And the other key points on here is that what else comes up when I lecture. When we do these courses, I'm sure you get asked this, Rich. Hey, can my physician make these dental devices? How about an ENT making these dental devices? And I think both the ADA and the next organization we're going to talk about feel that dentists are in the best position to be providing these. And I think that's key, that we need to work with the physicians for a diagnosis, but that we as dentists are the only healthcare provider who should be providing these. I mean, the ADA says it pretty strongly there, I think. The only healthcare provider with the knowledge and expertise to provide these. And they're indicated for mild to moderate apnea. Basically, it doesn't say you've got to try CPAP first there, does it? It says that we should be making those for people who have mild to moderate apnea or severe apnea when you can't tolerate a CPAP. And I think the last thing on here is something that's certainly been an area of controversy over the years is, can dentists use portable monitors? You know, what we're talking about here, pulse oximeters, or maybe even type 3 or type 4 portable monitors. And the ADA's position on it is we should be using those to judge the efficacy of our dental devices and our treatment. And so I think that that's something that's pretty new there, I think, for sure. It's worth talking about.
Yeah, the only thing I would add to that, guy, is we're not using our portable sleep monitors to screen patients.
Right.
You know, that gets into that sticky gray area of, are we really diagnosing or not diagnosing? So on the diagnostic side, work with your physicians. You know, we're always talking about that. But we certainly can invest in and use a home sleep testing monitor to help titrate the device. Good points.
Absolutely, and I think that we'll treat our patients better accordingly. Now, another organization who's been having their views and standards on dental sleep. We see some questions coming in. We're typing the answer to those as we go through. So we'll make sure we get to all your questions before we're finished today. Is the AADSM, the American Academy of Dental Sleep Medicine, and you know, again, neither one of these organizations can dictate what we as dentists do, but it's certainly worth us understanding what their point of view of how we should be treating our patients. And this came out in 2015, and you can read all the fine lines there. But what, you know, the abbreviated version of this slide is that, you know, guess what? Everybody doesn't wear their CPAP all the time, and that
Really?
So, yeah, I mean, that's a news flash to us in dental sleep. I mean, some people do, and we're thankful for those who do. But I mean, the real information's coming out, and that as much as 83% of the patients may be non-adherent. And these findings weren't just from the AADSM, the American Academy of Dental Sleep Medicine. They work with the American Academy of Sleep Medicine. So the two organizations work together to look at this. And I think down the bottom line here, when it says the mean disease alleviation calculations of oral appliances may be comparable to CPAP. I mean, Rich, how would you paraphrase what that said?
That means that when people don't wear CPAP all night, every night, but they will wear their dental device all night, every night. And by the time you figure out how many apneas you have and don't have, at the end of the day, we're treating most patients as well or better than CPAP is.
Absolutely. And you can look, this study's been around for a long time, where we're looking at kind of all the things that go together in treating someone for obstructive sleep apnea or sleep disordered breathing, when it comes to how well the CPAP works, how well a dental device works. When we say works, we mean by the top line here, PSG, so which one lowers the apneic index greater, which one does control symptoms. So these two lines, the dotted line is CPAP. And the solid line here is a dental device. And so we know that CPAP does a little better job of lowering what we call the AHI, lowering the apneic index. But we know that we're equal to CPAP for symptom control. And, you know, we both do a good job of symptom control. The further out the dot is on this line, the better it does in that particular category. They cost about the same. You know, they're both moderate cost. But, wow, a dental device is a whole lot more convenient. The bedtime partner would prefer it over the hoses and the cords and the noise that the CPAP made. The dental devices are much more tolerated. We adhere to them. And the health benefits are equal, more or less. And I think this has been a while ago, and I'm venturing to guess that this could even change in the direction of dental devices over time. And when you look at this, which one has a bigger piece of the pie? When we look at all the things that go into wearing this, not wearing it, where the AHI is, how the symptoms go, you know, which if they're at the very best equal, and if the way I look at that is, looks like dental devices have a little bit bigger share of the pie.
Yeah, part of it depends on what you're selling, Guy.
That's true too.
If you're selling CPAP, we just talk about that polysomnographic efficacy, because CPAP will frequently lower the AHI more, but you got to take all of these things into account. And by gosh, it's time as dentist, Guy, we stood up and started fighting for our fair market share in this, because we do as good a job most of the time, if not better. Yeah,
and we're going to talk about our free Dental Sleep Medicine Insider magazine that you can subscribe to at the end of the presentation tonight, and a great article by the inventor of the TAP device, Keith Norton is in this month's issue, talking about how times have changed and how the dental devices have come into their own. He'll also be talking at our symposium on that. So I'll give you that information towards the end of the evening here. But so the AADSM and the AASM came out, with that information about the adherence, 83%. Their clinical recommendations, and there are basically 6 of them, and this is a 50-something page report we can get to you if you need. Contact Jody or Brandy tomorrow, and they can get you a copy of this. But here's kind of the synopsis of it. Wouldn't you say, Rich? The 6.
Yeah, you just break it down. Physicians prescribe the dental devices, for patients, even with primary snoring. So, what I take from that guy is some of the studies are coming out with, even with snoring, we're starting to see changes in the epithelial cells of the heart and things like that. So, snoring alone, again, this is a guideline, but we should talk about treating it.
Right, and there's been several studies showing that dental devices that are custom made and titratable are superior to boil and bite over-the-counter ones. Not that those don't work. I don't want to bash those. They do help. But comparatively, ones made by a dentist, monitored by a dentist, customized devices work better. So they recommend that we use custom-made titratable devices. They recommend that we work with physicians getting prescriptions for these and patients who would prefer these or who are CPAP intolerant. And then we have 3 more here. We hit the slide advance. And again, the dentist should be the one doing these. I think we're all in agreement that they're just, if you've done any amount of these over time, you realize there's just decisions that even as a dentist sometimes are difficult to make. How's this going to affect this bridge? This person has periodontal disease or missing some teeth. It just the knowledge that we have as dentists to go into anchoring these devices, these teeth, really makes sense. It would really scare me the thought of someone with very minimal dental knowledge doing this. We want to work with sleep physicians for follow-up testing, and we need to see our patients because apnea is a progressive disorder. It's something that gets worse. One study I remember, what was it, 20%, Rich, over 5 years, I think was one of the studies that we have in some of our presentations that we deliver.
Yeah, and the thing I would throw in between there, Guy, now as I look at this, since I just see these slides you put together, is, the physician does the follow-up testing. But remember the couple slides before, the ADA says it's okay for you as a dentist. In fact, we encourage you to use that home sleep testing to find that right device. So that kind of falls in between that, when we do that. So yeah, and we need to instruct our patients about how to use them, how to return. We should be monitoring the side effects and the bite changes and things like that. And that's why we are the preferred provider for this. A physician that probably falls within the scope of practice, a physician can take it to that if he wants, but can he manage it? Can he deal, what is he competent to do that? And the answer most time is no. That's good, Guy. Those are good guidelines, and the AADSM as well as the ADA are both on our side as dentists. We should be doing this, and we can do it. And we've given you a couple of guidelines. There's a couple of questions coming in, Guy, about insurances and how they view all this stuff. And remember, insurance companies like to keep a hold of that money. They got a hold of it pretty good, so they will throw up some barriers here and there. But again, we need to fight for that. So I'm the guy with less hair. Guy, we'll have to update that photo. You look a little bit younger in that photo, but you look good tonight. Don't get me wrong. But Guy and I have been doing this a long time. We
since I was that young.
Yeah, we didn't get a picture of me with hair, so since I had hair.
I cut the top of my head off. I cheated. So we've been doing it for pushing 20 years each, so I think 30-something years between us, thousands of devices. We don't know everything, but we certainly know a lot, and we're here to help you. And by the way, we're going to talk now pretty quickly about some systems you need to put in your office to do this, and we hope a lot of you do. If you need any clarification or anything, just type in consult, and Jody or Brandy will contact you tomorrow. They can kind of see, where you are in your practice, what your goals are as far as dental sleep goes, what your challenges are, and they can help. I mean, Jody's been doing dental sleep for about as long as you and I have, Rich, I think 18 years. And so has Brandy, started with me probably 15 years ago. So, and if they can't answer the question, there's someone in our organization that will. No cost to you there, just type in consult. They'll schedule time to sit down with you and find out what your challenges are and see if they can help. This is what we do. We want to help dentists succeed at dental sleep. We put together our mission statement. It took us a better part of a day to come up with we're the most trusted, innovative, and customer-focused provider of solutions in dental sleep. We get up each morning at the DS3 office and Dental Sleep Solutions and decide how we're going to help dentists today. And there's a whole group full of people there. And we do it through education, coaching, software support, so that you can screen, test, treat, and bill for this procedures. And we're going to get to some of those questions in a minute. We're going to take a few weeks off here over the holidays because I'm certain everybody will have other things to do. I saw the billing questions you said was coming in, Rich. We'll be getting into some do's and don'ts. We've done on the billing webinars in the past, but we're going to kind of talk a little bit more about specific what you do want to do and maybe what you don't want to do. And we'll put the slide up towards the end.
That's always a popular one, isn't it, Guy?
Every time it's the most people, because it's you know, we got to get paid for this. And it's not just that the dentist needs to get paid. If you don't get paid, you're not going to treat patients. So this is essential to getting patients treated is to getting paid. So it's not just a selfish, hey, we want to make money here. We want to help our patients. And if you don't get paid, we know the dental offices won't do it as much as they need to. And speaking of help, we do courses all throughout the country. We're doing we have our schedules started up for next year, 2-day courses. I mean, you leave there knowing really the systems and everything that you need to do this. You get a sleep test on you while you're there. So over the one night, they're on Friday, and then Saturday's the second day. So Friday night, you actually get to wear a sleep test home and see how it works, and we'll review that on Saturday. You get a device. We make a dental device for you. We deliver those. You get to put them in. Do hands-on bites and so forth. And we go through each of the systems on how to be efficient at doing this. It's $9.95 for the 2-day course for you as a dentist and a team member. But I don't know. When I told Rich that Jason had decided to offer $200, and this is a true story, Rich goes, well, I don't know how I feel about that. That's pretty big discount.
It's already a good price.
It's already a good price. So if you type in course, I don't know that we've offered that much before, but $200 off a course. And you don't have to know which one you're coming to, but that'll secure that discount for you and a team member. So it'll be $200 off the $9.95. Again, we'll give you that later. Symposium, Rich, man, you're excited about it, I think, aren't you?
Yeah, I'm going to talk about, I've been spending a lot of money on external advertising, and we're still collecting data on all that. Guys keeps asking me, when am I going to get that PowerPoint done? And I'm still collecting data, and going through all that stuff. So, yeah, we're going to talk about a lot of different things, and we really focus on implementation. I think that's what's different about our meeting is that these are all going to be things that you can take back to your practice and you can use. We got people talking about home sleep testing and bites and, TMJ, and you're talking about developing physician referrals, Guy, and I'm talking about marketing. Keith Thornton's going to be there. Guy, you mentioned the DSM Insider. You guys can, that's a free magazine that we put out, and Keith Thornton just did a wonderful article in there where he talks about the ADA guidelines that they're putting out that we just talked about. So we would encourage you to do that. It's in the middle of February. Great place to be in Florida, Clearwater. Got a great place at the Hilton. The rooms are going fast. We got a great deal on the rooms. So I would encourage you guys to look at it.
$250 a night, but we're about to run out soon. They only gave us so many at that rate because it's normally over 400. So for right there on the beach. So if you want to consider that, just type in Symposium, or you can go register on the website there. Either way, and we'll hook you up. All right. So I think we've talked about, can we do this? Should we be doing this? The answer is you should. At the very least, you should be screening. I mean, the ADA says we should be looking for this, if nothing more. And so you've got to have systems in place to do this. And in order to treat your patients, you've got to be able to screen them, which ones are at risk, which ones aren't, have a way of getting them tested. We've got to have a way of treating them. We've got to have a way of billing. And we've been talking about the 4 pillars for quite a few years now, but nothing's really changed there. I mean, if you have systems for this, you'll succeed. And if you just can do these steps from screening, testing, exams, device delivery, you can be successful. Now, the first time you do this, it may take you a bit of time, but Rich, when we do this in our office with the systems we have, I think we can easily promise our members under an hour of dentist time. And we're not saying that to say we're doing a shoddy job. We mean that because you're doing an efficient service that patients will appreciate. It doesn't take a ton of the dentist time to do this.
And you can delegate a lot of it. Guy taught me that a long time ago. I'd say, hey, I did this. And he'd go, you know how long that takes me in my office? I go, hey, Brandon, will you? He goes, that's how long it takes. So you can delegate a lot of it, but there are a lot of things you can delegate in this, and it's easy. I think that's the one thing I want to say, Guy. We're not bending over, drilling on teeth and giving shots and, we're doing all this stuff. I think it's a little more challenging mentally in some ways because we're doing a little bit more medicine, but don't let that scare you off. Get your systems in place and that's what we teach. The courses that we teach really try to come away from that with a weekend. Number one, you're going to know if you have sleep apnea or not because you're going to get a test. And I'm pretty sure there's a lot of you dentists out there going, man, I think I probably have sleep apnea,
Yep.
But you really do. You go back and you do this, and it doesn't take that much time. And, that's probably the biggest question we get, Guy. Well, yeah, but where do my patients come from? And, what's the short answer? Where they're the ones walking through your door every day. There's a lot of people out there that have sleep apnea. I mean, when you look at this, there are 30 to 50 million somewhere undiagnosed patients who have sleep apnea in the United States alone. That's a lot of patients.
Yeah, 1 in 5 adults. It's starting to get closer to 1 in 4 by many people's estimation. So there's not a lack of patients. There's just a lack of patients know that they have the problem and then having successful treatment. And I've used these slides for a while, but I believe of all the things we'll talk about today, this is all you need. You need to believe that this is important, that it's my job as a dentist to at least be looking for these problems because no one else is doing it. 9 out of 10 people have apnea, don't know they have it. And if you believe it's your job, then you'll find a way to be successful. And all that really requires is having systems in place, and we can help you with that. So screening, Rich, we started doing this on paper and with my red flags I kind of used before, and I don't know if I was as successful as I am with the screening methods we have now, but I can tell you, as I started screening patients, I realized how many of my patients had this problem. And the next thing you know, I had a busy restorative practice, and I got busier and busier and busier sleep because these patients were patients I'd already known and been treating, and now I realized that they have an airway problem that may need to be addressed, and that may even have something to do with some of their occlusal problems that we could even go off on a large tangent that could take us 2 more hours, which we won't go down right now.
Or their joint problems, or tearing up the dentistry that you're putting in there and stuff like that. Yeah, but it's not all about money. We always talk about keep the patient's best interest at heart, and you never get too far off of that. But back when we were doing it with paper and that kind of stuff, Guy, I love the red flag thing that you started a long time ago. So patients wake up with morning headaches. What's the first thing a dentist wants to do, man? He wants to get his impression tray out and make a night guard,
right?
But it's more complicated than that. We don't want to oversimplify this, but when we look at these red flags, something in your brain, when you see this in your office tomorrow, yeah, I'm talking about tomorrow, something in your brain should go off and say, hey, maybe this guy's got an issue. We might need to get him sleep tested.
Yeah, and I think one of the things that you can do is just put the red flags, print these out, put them on a piece of paper, and just start getting your mind to say, oh, they're obese, red flag, GERD, red flag, just to where it becomes one and the same. Now, we make that a little easier for you in DS3. We took some of the more popular screening forms. We didn't, invent the screening. They've all been validated and used for years. We basically put those in. We stole them, repurposed them, whatever right word is, but we digitized them. Is actually the true word of what we did, and we were able to take these forms and make it so it's kind of an interactive questionnaire that the patients fill out, ideally on a 10-inch tablet or so, and they just go through and answer questions about sleepiness and comorbidities. And at the end of the day, when they answer these questions, it takes them 2 to 3 minutes. They get something like this on the screen if they're severe risk. And the thing that I really like about what we do, and again, we can, if you need some screening forms, we can point you to Stop, Bang, and Epworth, and a lot of things you could use. But what's different by the tablet screener is the patient has this in their hand, and they see this red arrow, and you haven't said anything. And the patient says, well, what is
severe risk? Severe risk for what?
Right. And that's
what do I do about this? Yeah.
Yeah. So we're not telling the patient's asking a question and we're answering it. And that's a whole lot more powerful than fill this form out. You're at risk for having sleep disorder breathing. When the computer kind of does this, it really makes a profound difference. Regardless, I mean, that's why we like our system a little bit better. Regardless of how you do it, we need a quick and easy way to say, in our practice, this patient may be at risk for sleep disorder breathing. And you need a system that works, and you can do this on most patients in under 5 minutes, and you're going to have a whole pile of patients at the end of the day if you start screening them. Because again, if you have adults in your practice, and the kids have this problem too, but that's an even more in-depth subject that we want to get into tonight. 1 in 5 adults has apnea. So you have 8 people in your hygiene room, you're going to have at least one of them who has this problem.
And they're not always overweight. Remember, 1 in 4 that has sleep apnea is skinny. And you go back to those red flags, big tongues, class 2. You can be skinny and have a big tongue in class 2. You can't breathe through your nose, posterior crossbite. You got to look at these people differently,
Absolutely. So if the patient's in their chair, they're here for hygiene, we screen them for some reason with a form or with the tablet screener, and they're at risk, and the patient says, well, I'm at risk for what? Well, you're not breathing at night. We're worried about you. Well, we need to have a way to measure that. So we like to measure your breathing at night to see if you're having any issues. And the patient will say, well, how do we do that? Well, you can do it one of 2 ways. We can have you go home and wear a little device at home that measures that, measures your breathing, or you can go to the sleep lab. Which one would you prefer to do? I think that's the key verbal skills there that Rich taught me, I think, years ago. And we don't say.
You know what I like about that too, Guy? You didn't use any big words. You didn't do anything to scare somebody off. You said, we're going to look at what's going on in your sleep and your breathing, and we got to do it. And you just give them an option, do at home or in the sleep lab. We don't say, do you want to get a sleep test or not? We say, hey, which would you prefer? I'll see you in a month and we'll talk about the results of your sleep test. Don't talk too much. You got to have a system, and don't get your hygienist behind. She's scheduling, she started screening these people, and if every time she finds somebody, you put her 20 minutes behind, she's not going to find very many of them.
Yeah, Rich's article, and the reason I'm laughing here is in the Insider this month is on not talking too much. So we'll see if we run on time tonight and see if that holds true. But yeah, it's a great article. There's 2 types of tests, PSG and HST. The HST is a little bit nicer in a lot of ways. If nothing more people will agree to getting the home sleep test. It's hard to get patients to go spend the night in the sleep lab, even if it was 100 times better, which we're going to argue in a moment. Maybe it's not. There's a lot of different ways of having people sleep tested. Remember what we talked about earlier. We can use these portable monitors once someone has a diagnosis to see how well our devices are working and make tweaks to our devices, moving the jaw, add in elastics, some of the things that we'll talk about in more detail in some of our treatment webinars coming up. But we can use them for that and reuse them to get the best jaw position for our patients. But we can't just do this device and say, oh, you have apnea. We have to work with physicians in one way or another. We'll talk about the 3 ways to do that in a second. And we're going to argue here in a moment which is better, HST, home sleep test, in other words, or PSG. And I think, Rich, you're the one that pointed this out to me. Who's making this decision a lot of times?
My wife. No, I think as a patient, Guy, when I ask that same question, you know what I usually get? Well, which one does my insurance cover?
Right. Right.
You know, that's really the most common, you know, question that I get back. So, you know, and it's a good question, and we should know that, you know. So we talk about, where I'm getting ahead of myself, but one of the things is billing, and you got to have some help with billing and how you do this. But, you know, Medicare started doing home sleep testing way back in 2011. And I mean, look at how much money they saved, you know, when they did this. So we saw a big jump in the home sleep testing there. And everybody's starting to follow suit now. So I know a lot of the payers across the country, they won't even pay for an in-lab sleep test unless you're an epileptic or you've had heart surgery, coronary artery disease. You know, there's a couple of things that they say, hey, yeah, maybe you should go to a sleep lab. But again, we're in a dental office, we're screening our patients, and we want to facilitate that sleep study. We're not going to just say, hey, guy, you should have a sleep study. I'll see you in 6 months. No, you got to use some good verbal skills. And if you haven't been to a course that Guy's taught, you should go do that sometime. I do a pretty good one, but he does a really good one because he gives you a lot of these verbal skills to talk about that.
Yeah. And there's a lot of different these home recorders out there. We're going to talk about the 3 ways of utilizing them. Ones you wear on your chest. One of our favorites here is the watch pad that just goes on the hand. It's less invasive in some ways, and the patient wears this at home. How we utilize this, there's 3 ways we'll talk about right after we have this little discussion. One of the things, if you come to one of the courses, by the way, $200 off that course. Just type course if you want our 2-day courses, which are normally $995. You can get $200 off if you type course during the webinar tonight. But if you come to the course, I'm going to give you the answer to something. Because I always say, who in the room thinks a PSG, in-lab test is more accurate? And then some people raise their hand. Who thinks a home sleep test is more accurate? And usually half and half, and well, a third of people don't raise their hand at all, but they don't make a vote. But we have to define accurate. And what I looked at this years ago and said, a PSG, it's probably a slightly more accurate test because it measures more data, sleep staging. There's people in the room watching you, but you're not going to sleep the same. You got all these wires on. You got John in the other room watching you on video camera, and it's not your bed. There's people down the hall. You're not going to sleep as well. So it's a less accurate night's sleep. And even if the home sleep test is less accurate, which it may or may not be by some studies, it's certainly a more accurate night's sleep. And so, what are we trying to measure here? We're trying to measure a normal night's sleep. So how we sleep is important. And if you don't sleep well, if you're nervous and you're laying there, you'll have less apnea. Apnea occurs when we sleep deeper. So we'll actually underestimate the apnea. So I personally don't think a home sleep test is any less accurate. My personal belief is that in many ways it's more accurate because I think the sleeping in your own bed trumps any advantages just for airway we're talking about here. There's a lot of reasons for in-lab tests for non-airway problems. But if we're just talking about whether someone's breathing at night and their oxygen is dropping down, then I think a home sleep test is a good way to do it. So if you got a home sleep test, Rich, I know you use them. You probably use all 3 of these methods in your practice, don't you?
Yeah, but it's nice to know we have options too, Guy, right? I mean, there's a doctor in my complex where I am, and he refers me a patient every now and then. Usually it's an obese guy, class 2, complaining about being tired all the time. He's got him on thyroid medication, vitamin D, iron, he's on testosterone, but he still can't stay awake in church, So, yeah, we can work with physicians to do that. Absolutely, we can. There are home sleep testing companies out there, and you can utilize their system for a referral. You can just, on DS3, we can click a button and we can get somebody to send the home sleep test to the patient's home, and then we can have a board certified physician read that and do that. So the payers are getting more sophisticated in how they're doing this. So again, all of these parts work together. So and there will be some payers where you will use one type of system, and there will be other payers where you use another one. And you have to learn this and you have to do it. But again, that's why we're here, because you're going to have 1,000 questions when you start doing this and who you're going to call. But Guy, these are all working. What I like is we are trying to lower that barrier simply to getting a test. Back 10 years ago, Guy, we said, hey, you got to go get a sleep study at the sleep lab. How many people did it? Like maybe 2 people out of 10 would do it.
Right.
Well, now that we have the home sleep test option, we're probably getting more like 5 or 6 or 7 out of 10 now that will actually go do it, especially if we use some verbal skills and create some sense of urgency.
Yeah, I think we can get much higher than that if we do create the urgency and use the correct verbal skills. So again, 3 ways of doing it. You can refer them to a physician. You can buy your own unit, and you can have that data read by a board-certified sleep physician there. And then there's companies that you can use. In DS3, you just click this button. It sends the data to one of the home sleep testing companies we work with. So that company mails the patient the test. The patient mails it back. They have board-certified sleep physicians who read that information and make an interpretation and a diagnosis. And we can go into more detail some other time about state laws and things that may affect those in individual states. But for the most part, that's the 3 ways that you can do. So, Rich, you've heard me say this is just like me preaching to my 11-year-old. You don't know how good you've got it. I tell them that all the time. And, those of you who are new to dental sleep, you don't know how good you've got it because we didn't have these 3 options even a little over 10 years ago. I mean, when Rich and I started doing this, there was only one option, and that was to go to the sleep lab. So we've certainly come a long way with this. So if we get the patients tested, I mean, I think that's the biggest 2 hurdles. If you can get through that, if you can just screen your patients, have a system to test them, you're going to have tons of patients to treat. And, we could spend a lot of time, and in our 2-day courses, we do spend that time. But I honestly feel that's the least hurdle for these dentists because you know how to treat patients. You know how to make impressions. You know how to make acrylic fit in someone's mouth. What you may not be as good understanding is there a lot of talking that goes involved in this. And we have to talk to our patients before we get started and during treatment about what we're trying to accomplish here. And I think sometimes if we don't have that conversation or understanding, then the treatment becomes complicated because we don't know what we're trying to do. And really, what are we trying to do? Why would anybody put this piece of acrylic in their mouth or slap a CPAP on at night? Why would they do this? And there's really 2 reasons. One is to help their symptoms. So either quit snoring, decrease the snoring, feel more refreshed, not wake up as many times at night. Or other people are more worried about their health risks. They know they could have a heart attack in their sleep. They want to lower the number of apnea episodes they have, and sometimes it's both. And so defining this with our patients and understanding that will help the treatment part more than I could talk to you about tweaking the acrylic and moving the jaw. It's understanding what we're trying to accomplish. And that's different for every individual patient that we may treat. We got to define that per what they want and what we see as important from a health standpoint.
Well said. Guy, you're breaking up just a little bit. If you keep doing that, I might recommend you turn your webcam off just so you can sound better. Not that I'm tired of looking at you.
Okay.
But, no, you put that very well. So again, the DS3 Experience, this is what we do. We help educate and coach you through our software platform and support. And we've talked a lot already about the screening, testing, treating, and billing and the 4 pillars. So we try to break this down into little chunks that you can learn and do. And we have an onboarding process. We have a member support team. That's all they do is answer the phone and answer all of these questions that you have every day. So I would just encourage you don't have to invent the wheel here. I mean, it's already been invented, and we've been doing this a long time. We've been helping a lot of dentists do this. So we know what the challenges are as you try to get your staff involved in doing this and all of those other things. And, just type in consult, like Guy said, and we'll be glad to, talk with you about how we can help you.
Very good. And Jody or Brandy will give you a call, set up a time, and just whatever challenges you have, they'll go through with you. So as far as the treatment goes, I'll break that down into a little bit more steps. Jason just texted me and said he didn't hear that on his end, so maybe it might be you. So hopefully it's not the audience as a whole. But again, we need to do a consultation, discuss the treatment goals. We need to have a way to take impressions in an exam. We get them the device. I like to see them about 3 or 4 weeks later. Some people want to see them in a week. I think if you give them a little bit of time to acclimate makes sense. We want to look at whether their their symptoms are better, as we talked about the 2 goals. And then we're going to do a follow-up sleep test, either that we can do ourselves, and then we refer them to the physician for a final test, or we refer them right to the physician for that. Then we're going to need to see our patients about every year, 6 months initially, and then about every year afterwards. So those are the treatment steps. I think one of the other questions here tonight was about billing. Are you still with me, Rich? I think you turned off your camera, didn't you?
Yeah, I am. I was maybe that's why I couldn't hear you. So maybe it's my internet connection. So I got my camera up, but I am still here.
Okay, fantastic. So let's talk about billing. And we've been using this analogy for a little while, and I think it just really hits home. Does anything make you nervous on here other than the fact we don't have a rubber dam on and doing those root canals?
Guy, I don't even know what a rubber dam is. I haven't seen one for 20 years. So you're asking the wrong guy. I mean,
okay.
You wouldn't want me to do a filling on you, let alone a root canal. But, I think if you can do a root canal, you can certainly do sleep medicine. But, we've been trained to do a lot of this stuff, haven't we?
Right. Yeah, and we haven't been trained necessarily. If you get a letter from your patient's attorney, are you going to go represent yourself? Or if the IRS audits you, are you going to be like, oh, it's fine, I'll go without my CPA? Or are you going to fly the plane when the pilot's having an issue? They're going to come back and grab you. I mean, you may do some of these things, but most of them you're not going to do as well as the plumber there if you do your own plumbing. I'm sure that they have the tools and the training to do a more complete job for you. So our point would be, I think the fallacy is dentists have been trained, or they have dental team members who have been trained to do dental billing and dental medical billing, and they think they can do medical billing because but it's different. Dental billing does not equal medical billing. It's totally different, and we will discuss this more in our webinar in January. But one of we're going to talk about the philosophy of billing, but the actual billing itself, we highly recommend that you get a third-party biller. There are many companies out there. We can refer you to one that does a great job, that all they do is help dentists bill medical claims. And until you get your feet wet and are really doing a lot of this, it doesn't make sense for you to do that yourself. So that being said, let's talk about the philosophy of this. What's this line in the sand, Rich? What are we doing here?
Yeah, everybody's wondering, well, can we bill dental insurance for this? You can bill dental insurance all you want, but they're never going to pay for any of it. So, we are billing medicine, and we're actually practicing medicine in a lot of ways. It's kind of weird, Guy. We have a dental solution for a medical diagnosis and medical problem that is quite complicated and sophisticated, yet the solution part that we have deals with everything that we are trained at doing. That's why all of these organizations that we've talked about already say a qualified dentist should do that. And in Texas, they say a qualified dentist is somebody should have taken some continuing education about this and done this, And I think maybe this is one of the hardest parts for most dentists, Guy.
Absolutely.
When you think about, when we talk about the fees, the ADA and the medical associate AMA, we expect, we think we're doing fraud, if we don't do this the right way. And in medicine, man, we write off a lot of this kind of stuff. And I think the biggest difference there, Guy, is that sleep apnea can kill you.
Right.
If you need a filling, it's probably not going to kill you. I guess it could, if you get a real bad infection or something. But it's just different, and that's one of the really hard things, I think, for a lot of dentists to get over.
Yeah, and we actually had a little internal email going around about some medical issues and medical billing, and my response to it is, I don't like the system, but it is the system. And we need to learn to play within the system. And when you go from cross that line in the sand and you make a mandibular advancement device on a apneic patient, you're doing a medical procedure. And so you need to put your medical hat on. And now we're in the medical arena, and we need to play by the medical rules. And so that's where you have to think about it a little bit differently. And if we think about that, the ADA, I think, is drilled into our heads, our dental schools. Everything we've ever been told is, look, if you take an insurance payment as a payment in full for a procedure without telling the insurance company that you're not collecting the other portion from the patient, well, that's overbilling, and something bad's gonna happen to you, right? I'm paraphrasing what this says, but that's what that that says there. So we collect the insurance money and we just take that as payment in full. Well, that's bad. You're not allowed to do that ever. Okay. Well, what does the AMA, American Medical Association, says that when you take these co-payments, if it's a barrier to needed care because of financial hardship, not only we're not going to get in trouble, we're unethical if we don't forgive that co-payment because we're denying that patient medical need care that's needed. And we should do this. It's actually 180 degrees opposite. And don't shoot the messenger here. I didn't make the system. Don't necessarily love the system.
Yeah, we didn't write the AMA Code of Ethics, did we, guys?
And we didn't. I've recently gone to the doctor a few times this year, and I found that this is the way they play the game there. And so we'll talk more about this in January, but just understand that you're playing in a different ballpark the moment you start into medical billing. So you'll have to make some decisions. We'll go into this in January in more detail. You'll need to decide about Medicare, and our first slide for that is, don't be afraid of Medicare. We love Medicare. We'll talk about that. You have to decide if you want to be in or out of network. What kind of billing system? Are you going to write off co-payments when needed? And are you going to do this yourself or do it through some third-party billers? Which the answer to that, we really believe, at least when you get started, is to do it through the third-party biller. I mean, really what it boils down to is this. Whether you're talking to a physician who may refer to you or whether you're talking to the patient, they not only want to know how much it costs, they also want to know their insurance kicks in some. Even if you say, well, I'm going to discount it because of we don't deal with medical insurance, you're still going to see less patients, I think, because of that.
Yeah, well put. That's a no-brainer, isn't it? The less a patient has to pay out of pocket, the more cases you're going to do. I don't care how good a salesman you are. I will tell you, Guy, I did 9 consultations today on new patients. And every one of them had those same 2 questions. How much does it cost? What does my insurance cover? So you got to have a system in place to do this. You can say, hey, we don't deal with insurance. This is what it costs. That's okay. That's one way to do it. But you got to talk with your team about it. You got to figure it out. And I think the communicating part, Guy, I think that's a hard thing for most dentists to do because dentists don't communicate by letters. The average dentist writes like 3 letters a year. But this is how we communicate with physicians. And I will tell you, Guy, I have built absolutely unequivocally most of my professional referrals because I write so many letters. I wrote 58 letters out of my office yesterday. In one day, we had 58 letters come out of my office. When do you write them? Right after you make a treatment decision. Did this patient show up? Did they not show up? I've had physicians tell me, Guy, hey, Rich, I keep referring you patients because I don't have to wonder what's going on with them.
Right.
You just keep me in the loop. You don't need to write 100 letters, but just, when you get started, hey, I've delivered the device. They're actually wearing it. They'll be ready for a sleep test soon. Hey, we're finally done. The other thing I like about that, Guy, is it keeps me in front of those physicians. That physician might read that letter, and then they walk in there, and the next patient goes, I hate that CPAP. What's he going to do? Hey, why don't you go see Dr. Drake?
Yeah, I want to mention too, Rich, you wrote 58 letters yesterday. You didn't stay awake for 36 hours to do that. You have an efficient system on how to do this. DS3 automatically helps you write letters. Sure, you got to tweak them and make some adjustments to them, but you can put these letters out quite readily with a system like DS3 that allows you to quickly generate the effort.
Yes.
Well, yeah, because it pulls the data from all the various areas and actually digitally faxes these right through the cloud, so you don't even have to print them. And a lot of you, or most of you, are probably in the general dental area, and there may be some specialists on there. But just consider, if you're going to do dental sleep, you got to act like a specialist. If you referred your patient to a periodontist or orthodontist, and you never got any correspondence from them, would you continue to work with those specialists in the dental area? I mean, when you say dentists aren't really good at this, general dentists aren't. The successful specialists are really good at this, okay, because they understand it's essential. So, we've already hit this, what you want to send these for, and who you want to send them to. And, I guess the only thing I'd put on this slide that adds, because Richie did a great job on that, I agree. I mean, you could hear the passion in your voice about this because it's that important and it works that well. But we also just include any physician they have when we send these letters, because with DS3, it takes no more effort to send it to all their physicians as opposed to maybe just their primary care, and it gets that same information in front of all their healthcare givers, which they should have and need, but also get your name in front of them as well. And there's how you do it in DS3. It comes with 24 letters that we already have. You can make all the custom letters you want. It pulls data from various areas of the patient's chart. Just makes that process a few clicks, and you've got your letters done. You're going to take these letters and you send them, and then you know what, Rich, do you ever have a physician call you and say, hey, I had a question about this? Or maybe do you actively call those physicians to make sure they received your letters and make sure that they don't have any questions? I'm assuming you follow up with a lot of them that way.
Yeah, well, I don't do a lot of that, Guy, but my staff does a lot of that. Sometimes I do, but you gotta. Physicians don't know what we can do.
Right.
They just don't. I mean, we need 100,000 other dentists out there, Guy, writing letters and going out and visiting physicians and doing this. If we could get 100,000 dentists to do that for 2 weeks, the market share for dental devices in the country would probably go from 5% to 50%. Right. So this is on our shoulders. We have got to go out there and educate these people. I like that word, educate.
Yeah, we talked to each physician may have a different view on this, but at the end of the day, we want to agree on how we're going to treat our patients and how we're going to refer patients back and forth. I think those are the two key things. I mean, so who's going to do the follow-up sleep test? How is that going to be performed? How are patients going to find my office if you want them to? Are you going to call me? You're going to, there's various ways, and this is what I'm going to be talking about at the symposium more in detail, but that's real important that you have specific protocols, and they may vary from referral source to referral sources. And when you meet these physicians, you want to talk to them about their practice, want to understand what their practice philosophy is, what their understanding of dental sleep is. Just like you said, a lot of them don't understand what we understand about it, and they kind of understand how that process works in their practice. I mean, if a patient has apnea, who's making those decisions as to whether they get a CPAP or other alternatives? If they can't wear their CPAP, how's that being tracked? A lot of times it's not the physician. It may be a nurse practitioner. It could be a physician's assistant. You want to find the key people in that office and develop relationships with them and make sure we have protocols that work. So again, I think last thing on this that I would mention to you is that we always talk about these practice parameters. Now we have the ADA to talk about. Are you going to be letting us see some patients who maybe would prefer a dental device over a CPAP if they have mild to moderate apnea? Are you going to follow these practice parameters if they can't wear a CPAP for any reason? Are you putting a dental device near the top of the list as to what's going on next? And then you can ask them how you would like this to refer patients. But again, I like to have something in writing. I like to be proactive with that so we don't lose patients. But we can go through all this, Rich, and wow, these look familiar, doesn't it? What's a physician going to say? You meet with them, they say, great, I'd like to work with you on some patients. They're going to ask you the same two questions that the patients are going to ask, aren't they? And they may ask you that last one too, but I guarantee you they'll ask the first two.
But you're absolutely right. Is sometimes patients do ask that, have you done this before? And a really good office manager would reply, why, hey, Dr. Yatros just made one yesterday. It might have been your first one, but we like that saying, fake it till you make it. But remember that physicians are going to ask these questions, and you need to be prepared, and you need to have a plan, for how you're going to do this, because they want to know that you are going to help reduce the patient's out of pocket. They want to know that you're going to help them bill medical insurance. They have to play that game. They don't have an option. Right. And they resent us as dentists because we don't have to play that game. But if, as a dentist, you say, hey, I do play the game. I feel for you, man. I hate dealing with medical insurance. Hey, it's the system, but we're going to do everything we can to help the patient do that. You probably, just by saying that, Guy, will probably win that referral source over. That's how important it is to the physicians.
Yeah, and so once they send someone over, so you've addressed their questions on insurance and cost and have you done this before, and they send a patient. Now, this should be, all hands on deck in the practice, and let's make sure we treat them well. And if that means we got to discount it to wherever they can afford it or whatever, assuming they're a good candidate for a dental device, let's treat them well. Let's send all those letters appropriately and timely. And then the key, I think, is you follow up. Hey, Dr. Jones, you sent the first patient over. Here's what we did for him. You got all my letters. What can I do differently? Are we on the same page? Are you happy with what we did? And if you'll do that, you'll have these physicians wanting to work with you. And maybe not all of them, but most of them will. It's really not that difficult. I think that continuing to follow up with these physicians, making sure that you write these letters and deliver a high level of customer service, treating the physicians themselves. There'll be people in those offices who have problems that you might be able to help. And if you need to discount some of the team members of making them a device. And then we try to maintain contact with these offices at least every 6 months to no more than a year. Ideally, you can see 3 months of some excuse to pop in their office to talk to them about a new device or something like that. But again, I think Rich hit it most when you saw how passionate he was about the letters. If you just do that, you're going to continue to succeed and get these referrals. So,
where do we go now, Guy? What do we do?
Yeah, we've gone through a lot. We want to emphasize continued learning. We continue to learn through our webinars we do and our training and the courses that we go to. And we'll have the course slide up again and be one of your last opportunities to get that $200 off our regular low price of $9.95 for the course. So come to our courses, go into other courses, reading. You have to have systems. I think that I think most dentists who try this and don't get where they want to go is probably those next two. They don't involve their team and they don't have systems in place, because there's nothing highly complicated about dental sleep, but there's just a lot of little moving parts, and you got to have systems through those slides that we went through fairly quick with all the steps. Meeting with physicians, we'll be talking about that at our symposium. Increasing awareness, Rich. I mean, you've been preaching this forever. That's the biggest problem. People don't know that we have these dental devices out here and that they work, and that's everywhere from your cleaning lady to a cardiologist that aren't aware. I've met them all. And I think if we can just talk about this when you're out in public, and what do you do? Well, I'm a dentist, but I get involved in dental sleep. And I put this one in here, and I want to make sure that if your local state dental society wants us to think about how dentists should be involved, if you're involved with the ADA and then we're tweaking these standards as we go forward, get involved and stand up for where we should be involved in this. Dentists should be involved in this, and make sure that and there's state by state laws that come around that make sure that if those things come up, because you got involved in that in Texas pretty heavily, right? A year or so ago, Rich?
I have, and I think you put that very well, Guy. Get involved, and if you can't do it, you call us, and maybe we can go talk at the local society or something like that. But don't, let's. I'm tired of us as dentists, kind of wimping out on a lot of this stuff. We need to start standing up and, educating not only the physicians and our patients, but start doing talks at the Rotary clubs and the Optimists and the Lions and your church group and all of these other things. If so many more of us were out there doing that, we would. What do you say, Guy? The rising tide.
Yeah, all boats rise with the. I don't know. I put me on the spot. Yeah, but all boats rise.
The rising tide, it floats all ships. We all go up. If we do that. And we certainly hope we can help you do that. It doesn't take that long to do this. Again, you can delegate a lot of this stuff, but there are systems. We could talk about every single one of these things for probably 6 hours. So we hope that a lot of you put in course and all that other kind of stuff. So that's fantastic.
Yeah, again, if you put in consultation, I know we went through some things that we touched on a lot of different subjects that it could be an hour or two in their own, as Rich mentioned. And if you want more clarification, just want help, just type in consult. And one of our trainers, Jody, Brandy, someone will get a hold of you, set up a time, and we can just see where you are, see where where you want to go, see what your challenges are, see if we can help you. No obligation, and I think you'll find it's worth your time just to get your questions answered from that. Again, the course is coming up. We'll be adding more dates, but I mean, it's a great deal. $995. Like I said, I think Rich about had a heart attack when I put up the $200 off. But I mean, you get a sleep test, a dental device made on yourself, so custom-made dental device from the lab, plenty of hands-on experience, as well as leaving with the systems in place to do this in your practice. And so it's a fantastic course, a type-in course, and you'll get $200. Even if where you want to go, you're not sure, you just type that in, and that'll secure the discount for the time being. And you don't have to do a lot of this to make a huge return on your money. If I think we're very conservative when we put these figures together at $2,500 a case, average lab fee at $350. We have labs through our DS3 members that are closer to $300 with discounts, but we even put the $350. And even if you're going to pay a third-party billing company to do your insurance at $200, if you just do one case a month, and you pay for DS3 even, you're pushing $20,000 a year additional income that you're going to make. I mean, I'm not making up games here. Oh, hit the wrong button. If you do one a week, you take 4 weeks off, you're pushing six figures, just south of six figure, $90,000 that you can add. So, I mean, I hope that's not the only reason you all would want to get involved in dental sleep, but it certainly is a nice reason why you can make money while you help your patients. And again, the consultation, we can talk to you about how we can help you. There's the Dental Sleep Insider slide. So you can just go to that website, type in dentalsleepinsider.com, sign up. You can see all the past issues. I think we have 20-something issues. You've been in the office lately, Rich. Have you seen down the hall, we have all the covers, and I think there's 20-something issues that you can view that are in the back. Issues of this.
A lot of good stuff in there, man. It's free, really good, and it's free. Yes. Yeah.
So it comes to your inbox. Videos. Rich did a great article on not talking too much, which I think we've done fairly well because we'll finish here almost on time. And again, Keith Thornton's articles in that latest one. We'll be doing this webinar in January. So usually we go about every other week, but with the holidays, we decided to wait until January, and we're going to be doing medical billing do's and don'ts. So make sure you write that time down on a Tuesday night, I assume it is. There's how you can get a hold of us. And I know a lot of questions have come in that everybody's been typing the answers to. Richard,
I think we're good, Guy. I don't see anything in there that we haven't addressed. So I think that's it, Guy. Thank you for putting together a wonderful PowerPoint, and for our team for being on to help with all of this stuff. And thank you guys out there. Hope everybody has a wonderful holiday and stays safe and has a healthy, happy new year.
Absolutely. Thank you, Rich, for taking the time too. And again, we're going to shut down here in a second. So if you have any other questions, just remember info@dentalsleepsolutions.com or call us at 877-95-SNORE, which either one of those you should be able to remember. And we thank you for taking the time to spend your evening with us. And I think that's it, right, Rich? We got everybody answered. Yes, looks that way. So I'm going to end the presentation. Have a good night, everybody.
All right, guys. Good night.